who is working in our department. We are very proud of having him because I think he's maybe the only one or one of the very few people trained in India in lung transplantation. And so he has a very bright future for surgery in India. I'm sure he will do us proud in future. So Dr. Pramoj, can I invite you for your talk on role of surgery in pulmonary tuberculosis? Is it needed in 2015? And I request you once again to restrict to 6 minutes and have an eye on the timer in front of you, so that we have 2 minutes for discussion.
First of all, thank you, Dr. Agrawal sir, for such kind and nice words. Good morning, everyone. So my topic is a very common thing, which is pulmonary tuberculosis. And the thing is whether the surgery is needed in 2015 or not. Now, the history of thoracic surgery is equal to history of pulmonary tuberculosis. The thoracic surgery went on to, as per the history of pulmonary tuberculosis in last 200 years. Though the first case reported of thoracic surgery was by Hippocrates, where he drained a empyema. Now, it has been a roller coaster ride in the last 150 years. There was a tremendous increase in the volumes of thoracic surgery in 1900 when there was urbanization and increase in pulmonary tuberculosis. But then came the streptomycin era and the anti-tubercular era, which said that thoracic surgery won't be needed anymore. But with the coming up of HIV and other immunocompromised states, MDR and XDR-TB, the thoracic surgeon finally have got something to do, and again known as a poor man's branch. So in 2015, whether the surgery is required or not, the answer is yes. But when? What are the indications? So that we would be discussing. And to your my surprise, I found that 5 to 10% of people of pulmonary tuberculosis will be requiring surgery one or in their lifetime. It may be relapse, it may be anything else. So let's see what are the indications. Though thought very less, but the surgery for diagnosis, though less indicated because of the interesting tools we have in form of bronchoscopy, EBUS or something. But even after that, around 2 to 5% of the cases which you are treating by ATT would require a surgery for detection. And those are basically pulmonary lesions which are of unknown origin. This is around 48-year-old lady coming up with multiple nodular lesions in the bilateral lung, bilaterally. She was receiving ATT for last 4 months. They refused to die off, and therefore we had to do a diagnostic thoracoscopy and take out the nodule. It turned out to be tuberculosis. What it also helps you is taking a sample for your cultures, which might not be available in other modalities. The another thing is, if there is a mediastinal lymphadenopathy of unknown origin, again you have given a ATT for few months, few weeks to months, and it keeps on increasing. What to do? And the second thing is whether it is tuberculosis or not. EBUS comes to a big rescue, EBUS and EUS, but if you don't get a sufficient diagnosis, which you all must have seen, if you are pushed to the wall and differentiating between sarcoidosis or tuberculosis, what to do? Then comes the role of biopsy. So not every patient, only a selective patients for diagnosis. And this is around 50-year-old male patients. As you can see, there is a big lymph node near the superior vena cava, and this was the EBUS wasn't able to give you the diagnosis. So we went ahead and see, these are the nodules which are in the inferior pulmonary ligament and that region, and these small nodules over the lung parenchyma, which you cannot take by any means. So those, and few of them also onto the parietes as this nodule. This might be even a plaque, which might be even a mesothelioma, you don't know. So in those cases, you might have to do a diagnostic thoracoscopy, but I'm not saying it would be the first investigation, but definitely one of the things which you should think for making a diagnosis. Now, if you see this lymph node, this is very near to the superior vena cava. This is superior vena cava, And taking out the lymph node from here, either by EBUS or EUS is not possible. EBUS would be a little trickier. So if it doesn't, if it refuses to die out, you can take it by video thoracoscopy. So this ultimately turned out to be sarcoid, and therefore the treatment modality had to be changed a little bit. Now the second indication, which would be more important, would be complications of scarring after you have given an ATT for 9 months or 10 months, and it might present to you at any given point of time. It may be even after a few years of thing, and massive hemoptysis comes up with a little bit more commonly nowadays, as there are a lot of scarring and they can bleed. Though the first line of treatment would be conservative, either a bronchial artery embolization, because most of them are bleeding from the systemic circulation, but they may, if the chances are 50%, would relapse even after bronchial artery embolization, and these massive hemoptysis can be fatal, and therefore you might need a surgical intervention for them, which might be in form of segmentectomy or an pneumonectomy or this. Now this was a very interesting patient, came with a 2 years ago, a whole lung is destroyed and he was bleeding from the right upper scar. What do? It's a tricky situation, because you have to take a patient on a single lung ventilation, so he had to be taken onto heart-lung bypass and then we resected it. Fortunately, the patient did not bleed after that and went home on the 7th or the 8th day of our surgery. But not all patients will be so difficult. Second would be bronchiectasis, and this bronchiectasis is not important until unless it bleeds or there is recurrent infection. And this is a recently done case wherein this is a around middle-aged female who had a post-tubercular treated bronchiectasis. We did a lobectomy because it was entire lobe was involved, and we could do it by video assisted. And the beauty is that the patient doesn't have much of, you are getting all the benefits of a laparoscopy or a thoracoscopy even in a tubercular resections. And these we all must have seen aspergilloma or a mycetoma, which keeps on coming after treatment. It would be years after treatment you get these. The important thing is that 50% of these will have hemoptysis, but not all hemoptysis will require surgery. Only 1/5 of those will have massive hemoptysis, and the only effective treatment in these type of aspergilloma is surgery. And therefore, the earlier to be done, the better it is, as the patient would be much more preserved in these cases. This is what we did in, I think, 2014. Failure of medical therapy will definitely would be an indication for surgery. The most important thing is that if you don't see any improvement or the disease progresses after 3 months of treatment, you need to think that whether we need another biopsy, whether we need a resection of that thing. It might be, and let me tell you, we encounter around a case or two every month wherein it's a failed diagnosis of lung cancer being treated as tuberculosis. So a tissue diagnosis should always be thought of. Now, the last and very commonly what we encounter is the pleural tuberculosis, and that would be in form of empyema or this bronchopleural fistula. As I tell you, this is the most common things, most common surgery what we do. Now, not all tubercular empyema need surgery, as I said, but here the first would be control of infection by ATT or regular needle aspiration. The problem will occur when it doesn't go away and you have to obliterate the empyema cavity. And whatever be the thing, thoracoplasty or pneumonectomy or thoracentesis, the treatment of choice are early decortication when the infection has subsided or is controlled. Now, as you see, a big empyema, the lungs have cleared, though it is not the lung window, and then we do a decortication. The morbidity of decortication has again decreased by the use of VATS or thoracic thoracoscopy. Yeah, this is what we are forced to do in some patients, a thoracoplasty. And thoracoplasty means you remove the few of the ribs to collapse the cavity which has been formed. Earlier, it was very much in use, but because it's a very, very morbid procedure, that we try to restrict to a very, very selective few individuals if we have to do. And particularly in MDR TB, which are not getting relief, you might have to do this to collapse the cavity and the loop. And this is what was very much used in World War II, but it has again came up when the entire, if you see this thing, this is a empyema, but the thick peel would not let the lung expand even if it has been removed. So what you do is you make a window in the lower part of the chest and it drains out and it heals with secondary granulation. The patient can do his or her work for the entire period of time, just needs a dressing. And with the use of VAC, you can actually expedite the healing process, but the cost would be enormous if you use a regular VAC. And pulmonary dissections would be the last resort or the first resort, depending upon the indication, whether it is hemoptysis, bronchiectasis, or infection which is failing to die out. So our experience has been a total of 124 cases in almost a little over the last 5 years. Diagnostic thoracoscopy, not all of them turned out to be tuberculosis. Many of them turned out to be malignancies, sarcoidosis, or some surprises for us. We have done more, we get more of empyemas to do decortications, and 60 to 65% would be done by VATS. Segmentectomy, wedge resections, lobectomy, all can be done by VATS or thoracoscopy, so the morbidity is less. Though we have decreased doing this thoracoplasty and allosaurus flap, as these are morbid procedures, but sometime you would be needing to do it. So in my conclusion, I would say that surgery in pulmonary tuberculosis does form a sizable number. If you pick and choose, it can be as high as 5 to 10%. Tissue diagnosis should be a priority if your initial treatment is not, the patient is not responding. Anatomical dissections do far better than just curettage or something, and they give you a very good life. Surgical interventions in case of non-responders is a must in today's era, particularly also having a medical-legal implications if it turns out to be malignancy later on. And definitely good results functionally, cosmetically are feasible by VATS, which we have been doing. And this is our thoracic newsletter, a biometry newsletter. You can visit it, and thank you for patient hearing.
Thank you, Dr. Pramoj. And